How many of you are ready for a 1-hour pregnancy? Woo! Wouldn't that be handy? I'll tell you, that would be great. So we're going to talk today about pregnancy as it pertains to primary care. And so the key with pregnancy and primary care is really know when to hold them, know when to fold them. When in doubt, get a consult or a referral to OBGYN. Do not take chances. I know we have some labor and delivery nurses in here. How many do we have? All right, great. So you agree? You agree with that recommendation? So it's really important to remember the basics because you may not see these patients all that often. So you're going to get really good at what you see often. And when you don't see patients that are pregnant that often, you need to be extremely careful. The good news is in pregnancy, you can kind of put everything into 3 little boxes. First trimester, second trimester, third trimester. So that makes it pretty easy to organize. So this is our outline for the next quick hour. And you're going to have a lot of patients that ask you questions and have common complaints. And in the midst of those, they may have some serious issues in the midst of those complaints. So you've always got to try to be looking for those red flags. So first trimester includes from the point at which patients don't even know they're pregnant. Because half the pregnancies in this country are what? Unplanned. So that's why the CDC wants us to make sure women of reproductive age are taking what? Folic acid. This is a call to action that's a couple years old now, so it might be on your exam. And so all non-pregnant women should be on folic acid. When we confirm they're pregnant, then that amount goes up. And I have a separate slide for that, so hold on just 1 minute. So from the point at which they don't even know until 14 weeks is first trimester. And first trimester is a very busy time in terms of what you need to know and what's going on with the patient. So when we look at this short list, that's a lot of information. So we're going to go through all of it bullet by bullet, but you always want to make sure that your women of reproductive age are updated on their immunizations, because what can't they take in pregnancy? Live attenuated vaccinations. So every time you see them, whether it's for strep throat or this or that or a sprained ankle, you want to double check and make sure their immunizations are up to date. That's opportunistic screening. That's really proactive preventative care. So you kind of have to train yourself. So what statements about folic acid are correct? We haven't gone through these details yet. It's kind of backwards, but it's still good as a preview. So all women, select all that apply. All pregnant women should take 1 milligram or 1,000 micrograms daily. True or not true? True. If they're pregnant and we've confirmed they're pregnant, that's how much they should be taking. How about number 2, before pregnancy, they should take 0.4 milligrams or 400 micrograms daily. Yes, that's true. That's very true. So circle that. How about number 3, prevents cleft palate? Is that no, that is not true. So don't circle it. But what about number 4, prevents neural tube defects? Yes, that's the whole purpose behind taking folic acid. And we want that on board before they even know they're pregnant. So that's really critically important. So the correct answers are 1, 2, and 4. So folic acid, this recommendation has been out long enough that it could be on your exam. And remember the doses. And don't be mixed up by milligrams versus micrograms, because they could have a trick answer on your examination. So that's why we put the micrograms in parentheses next to the milligrams. And now this is a clinical question. It will not be on your exam, but you know what? Clinical is real. So you're going to see patients that are not using birth control, right? Probably a lot of them. How much folic acid should they be on? 1,000, right? 1 milligram or 1,000 micrograms, because they're at high risk for having an unplanned pregnancy. That's a clinical question, not going to be on your exam. So symptoms of pregnancy. What's usually the first symptom? Uh-oh, I'm late. Should have come last Thursday. It's a week later. Uh-oh, I'm late. So late or light missed menses. Late menses, menses that's different, all potentially concerning. And how about frequent urination? Is that common? Very common. Fatigue? Very common. Like it's a hangover that will not go away. How many of you had a little nip last night? Good job. As long as you can sit up today, you're good. Nausea and vomiting. They may or may not have it. It may be severe, it may be mild, it may not even exist. That does not tell you the quality of the pregnancy. There's a lot of mythology about that. But if patients have severe vomiting, they need to go to OBGYN. They are not your patient because it's critically important to have them in the hands of that expert in order to manage them. Breast tenderness, does everybody get that? No, but it's very common. So one or more of these may be present in any pregnancy, and they're all variable. For one woman who has multiple pregnancies may feel totally different from one pregnancy to another. So nausea in pregnancy, this is late breaking. It will not be on your exam. But you want to avoid Zofran in first trimester now because the CDC is telling us and the FDA is telling us that there may be an increased risk for teratogenic effects. You may still see it given in clinical practice because it takes 17 years for new information that's important for clinicians to act on to reach all clinicians. That's not you. You're going to be proactive. You're going to keep on top of it. So how are we going to help patients deal with their nausea and vomiting? Ginger ale, saltines. It often is helpful if patients dangle on the side of the bed and nibble on saltines and nip on ginger ale until they kind of get their wits about them. What you can prescribe is brand name Diclegis, which is basically an antihistamine and B6, and it often helps patients, particularly if they take it at bedtime. So I've given you the recipe for that, and that is safe. It's been around a very long time, and so you have an option. But do not prescribe Zofran because if the patient ends up with a problem, they're going to look at everyone and who prescribed what, and you could be in a serious problem. You don't want to jeopardize your prescribing or a patient's life or a baby's life. So diagnosing pregnancy, basically urine tests are about as good as blood tests if it's a healthy pregnancy. Now, if it's a tubal pregnancy, that's not the case. So just so you know, we tend to do serum tests because we can trust them more. So if they ask you on an exam, that's definitely true. And we don't trust home tests. We can get an inkling. If they say I did 6 home tests, they were all positive, you're still going to do one in the office to document that objective finding. So we're testing for human chorionic gonadotropin hormone. And don't worry, we'll talk about tubal pregnancy shortly. This is something you're never going to have to do, the manual way of figuring out when a patient is due, but you might have to recognize Nagel's rule on an exam question. I have no clue why they haven't ditched those exam questions. So it's just the old manual way. Now what do? You got a wheel, you got an app, there's some other way you do it. You do not do this math. Unless you're really into doing the old-fashioned way. So patient history. When we see a pregnant patient, how many of you have done these visits where you have to ask soup to nuts everything about their history and you've had to, sort of do the whole comprehensive first visit? It takes a long time. You're in it for a while. If they say yes to every question, good luck seeing more patients the rest of the day. It can be very, very time consuming. So we're going to ask everything about their history, current pregnancy history, past pregnancy history, menstrual history, personal and family history, past surgical history, and how about genetic history? How important is that? Critically important, especially when we're dealing with women that are older. And what's the cutoff? 35. That's when we call first-time pregnant woman what? I hate that term. Elderly primip. And maybe they'll even get something from AARP like I did when I had my first pregnancy at 35. I'm like, what is this? This is terrible. Psychosocial information is critically important because if patients are in any kind of threatening relationship situation, that risk goes up in pregnancy. So you want to really dial in on those risk factors. And so much so that ACOG, remember what that stands for? The American College of Obstetrics and Gynecology, wants you screening all pregnant women. And we ask at every single visit, are you safe in your world? And you should ask every patient you see, are you safe in your world? Because we live in a very scary, dangerous world. And you never know who's at risk. So I started doing that in the emergency room not so many years ago, actually quite a number of years ago. And I was shocked at how many affirmative answers I got. So when patients know that what they say to you is safe, They trust you. They trust us as nurses. We're the most trusted profession, right? So that's going to translate to you as a nurse practitioner as well. So we know that domestic violence screening is critical and that the risk goes up in pregnancy. As many as 20% of pregnant women are physically abused. So we have our work cut out for us to identify these patients because they're pretty good at hiding it. And you will find that. And they are much more at risk if they have had an unintended pregnancy. And what percent of pregnancies are unintended? Half. So you might as well just divide it up. Half of the pregnant women you see are going to be potentially at risk. They have more medical problems, and they will have more complaints as well. They will perceive more pain as well if they have a history of sexual abuse or any kind of domestic violence. So just review your risk factors. And sometimes they don't seem to have so many risk factors, but they're still at risk. What are domestic violence clues? Let's figure out what we've got here. Select all that apply. More specifically related to pregnancy scenario here. So how about a missed prenatal visit? Very high risk, so let's circle that. How about an overly supportive partner? This is a trick answer. Don't circle it. An overly protective partner is a high risk. You'll find them hovering where you can't disconnect that partner. They look like they're overly concerned. So don't circle number 2. How about bipolar disorder? Not necessarily. How about a history of childhood abuse? Yes, a huge risk factor. And how about improbable injury? Huge risk factor. So basically 1, 4, and 5. So domestic violence clues, you just want to make sure you review these lists. And in your practice, if you have a pregnant woman who doesn't show up for an appointment, this is unique. You're not going to call every patient that doesn't show up for an appointment. But if they're pregnant, you want to call them up to make sure they're okay. You don't have to specifically do it, but you must train your office to do it. And sometimes patients can't talk on the telephone. So you've got to get to kind of a sixth sense of how much you really need to worry about patients. And remember, we have human trafficking problems out there. And in fact, I think you have a lot of human trafficking problems in Texas, right? So make sure you're really dialed in on that as well. So when it gets time to do the physical exam, you all are going to do a much better exam than an average OBGYN. So you're going to get baseline vital signs, including weight. Now, blood pressure is critically important to get. If you work with a medical assistant that gets the same vitals on every patient, 110/70, heart rate 70, take your own vital signs. You're laughing because you've all worked with people like that. We all have. So you want to do a complete physical exam, including cervical cancer screening, if they are due for that, but gently. You're not going to take that cyto brush and drive it in as far as you can. You're going to take, ideally, either the broom gently and sample both the canal and the outer cervix, or the spatula and the broom, whatever. The broom, remember, samples both, so that's good to go, and that's a great option in pregnancy. So what blood tests are we going to do? I'll tell you right now, if you're going to make a quick referral to OBGYN, meaning they're going to see OBGYN within a few weeks, you're not going to do many blood tests. You might do a confirmatory pregnancy test, but if you do all the lab tests that OBGYN would do or midwifery would do, they're just going to repeat them unless you're within the same system. If you're in the same electronic medical record system, that may not be the case. So make sure you don't waste the patient's money. So we're going to do that pregnancy test, first things first. And in a normal pregnancy, that HCG doubles every 24 to 72 hours. We give it a little extra time now because some patients just don't produce as much. But if there's a tubal pregnancy, that doesn't happen because the pregnancy's in this teeny tiny little fallopian tube, the diameter of the lead of a pencil. It can't grow much, so it can't produce much HCG. So that's a good way to kind of think about it. And you want to, on an exam question, determine the difference between qualitative, that's yes or no, and quantitative, which is amount, quantity. And you're always, when push comes to shove, going to check a quantitative because you're usually going to want to figure out, is this a healthy pregnancy or could it be in the tube, especially if they're having symptoms. And the hallmark symptom is left or right lower quadrant pain. So that's always of huge concern in a woman of reproductive age. It's such a huge concern, you want to get them out of your office as fast as you can. because the point at which they start having symptoms with a tubal pregnancy is when they can rupture. So the quicker you can identify these high-risk patients, the better. So what statements are true about pregnancy testing? Select all that apply. So we're looking for correct answers. Number one, in a normal pregnancy, urine and blood tests are about equally accurate. Is that true? In a normal pregnancy, that's true. So let's circle it. Remember, we're looking for correct answers. Number two, if an ectopic pregnancy is suspected, a qualitative HCG test should be ordered. Serum HCG test should be ordered. Is it qualitative or quantitative? Quantitative. So this is incorrect. Let's not circle it. How about number three? If a home urine test is positive, an in-office test is not needed. False. Let's not circle that. You're always going to confirm with an in-office test. Number four, urine testing can be done as soon as a missed period occurs. Yes, but you often have to repeat it. So ideally, you want to wait about a week from the missed period to really check a urine test. So let's not circle that. So let's see. One is really the only correct answer. So make sure you circle number one. So when prenatal lab tests are collected, we do a lot of testing. So if the pregnancy test hasn't been done previously, we got that checked off. We always check a CBC because often women start out anemic, and then they can be at very high risk for anemia in pregnancy, if they are, but also even if they aren't, because the baby just sucks the life out of the mother, sucks as much iron as they can away from the mother, so the mother is inherently at risk. So remember that that's something that you're going to check baseline, and then if she has a history, you're going to check multiple times during the pregnancy and probably have her on iron. And prenatal vitamins have iron in them, but often we give extra iron. So what else are you going to do? Are you going to check a urinalysis? Yes. Are you going to do a urine culture routinely? Only if they're high risk, yes. If they're not high risk, no. You're always going to do a urine culture if they have asymptomatic bacteria. If they have no symptoms and they have bacteria in their urine, you're always going to send a culture because they're at high risk for what complication in pregnancy? Preterm labor. So they really have to be high. You just always have to be thinking, oh man, they're high risk. That's why every pregnant woman that comes into a clinic for a checkup pees in a cup, right? Because we always want to make sure they're okay, that they're safe. You're going to check a blood type and RH. And remember, we're going to talk more about that with another slide. If they're immune, they don't obviously need rubella immunity. If they're not immune, are we going to give that immunization? No. Hopefully they're in a system where you've updated them so you don't have to worry about it in pregnancy. And if not, we're going to wait until after pregnancy because that's a vaccination that's what? Live, exactly. Live attenuated. Good job.